So quickly, just to introduce myself, my name is Dustin Pedivis. I'm a product manager here at Accurx, and I'm the product manager for the PIFU team. And I'm really excited about the webinar we have set up for you today. We've got some lovely speakers kind of internal to Accurx, and we also have some lovely speakers from the University Hospital of Leicester, and we're going to be talking everything PIFU. Just a little bit of kind of setting the scene for the session today. As we go through the session, if you have any questions, feel free just to put them through the Q&A functionality. And at the very end of the session, we'll get to the questions and answer them appropriately at the end. So with no further ado, I'd like to kick things off by handing things over to Satya.
Thanks, Dustin. Hi everyone, I'm Satya, I'm the head of clinical here at Accurx, and my role is very much to support our growth across secondary care. For those of you who are new or familiar with Accurx, we're a software company based in East London, and our vision, rather uncontroversially, is for a health system where everyone involved in patient's care can communicate with each other. Our software connects staff and their patients across every care setting, whether that's GP practices to acute community and mental health trusts, pharmacies, hospices, and lots of other NHS services. We started out very much in 2016, pretty much living and shadowing in a GP practice. And it was there that we discovered the everyday problems that healthcare staff face center on one thing, and that's communication. Whether that's speaking to a patient, coordinating care across multiple services, making patient referrals, or asking second opinions. Healthcare staff spend many, many hours of their day communicating with each other and with patients. But we've also seen how fragmented that communication can be, and how ultimately that can negatively impact both patient care and the ability of healthcare teams to do their jobs well. So the first thing we did was make it really easy for GP practices to contact their patients via text messaging, then for patients to contact GPs through online consultations, medical questionnaires, and much more. And then at the start of the pandemic, so very early in kind of February, March 2020, we built video consultation capabilities over the course of a single weekend and the ability to remotely monitor patients at home with COVID. We also built a booking solution as COVID vaccines were being rolled out, enabling healthcare staff to set up vaccination centres. And to date, almost 30 million vaccines have been booked using Accurx nationwide. By spending lots of time with frontline staff, understanding those workflows, building those task-based efficiencies, we're now in this incredibly privileged position where today 98% of GP practices and their staff and over 50% of NHS trusts use Accurx every day. And we've been used to message over 50 million patients, roughly 2/3 of British population. Next slide, please. And today we're really excited to be joined by Aimee and Sandie from the University Hospital of Leicester, who are here from Leicester, to talk about patient-initiated follow-up, how we approach it and why we think it's so important and crucial to supporting elective recovery. We're really excited that UHL are one of our flagship partnerships using our PIFU solution within their trusts, and you'll hear lots more about how they're implementing it there. So why are we focusing on PIFU or patient-initiated follow-up? So we know that waiting lists are at an all-time high across the country. Healthcare teams are being asked to free up outpatients lots more and more and move patients to patient-initiated pathways. So that's when a patient's already known to a service, is under the care of a service, and can get in contact with that service to let them know that they might need to be seen, and they've had a change in their medical condition, or anything else. And as many of you will be aware, that's part of the phase 3 of the NHS recovery plan, staff being asked to implement PIFU so that patients can book follow-up appointments when needed, instead of them being set at scheduled intervals. So these are patients who are known to that or under the care of that hospital service already. And the NHS is targeting a reduction in follow-up appointments of 25% by March 2023 to make hospital visits more efficient, reduce that waiting list, and help to improve that patient experience. Next slide, Dustin. Thank you. And we spend a lot of time speaking to staff, and our research shows that most trusts implementing PIFU are currently doing that via phone lines. So that's patients phoning in about their care. Now, given the lack of technical infrastructure, the capacity for training, it's completely understandable that overwhelmed services, especially after the last few years, have turned to phone lines to implement PIFU. But we know those phone lines see really high call volumes, causing patients to find other routes to get help, and are really inefficient for staff who are ultimately having to manage those phone lines, resulting in delays in treatment time. So because of that, there's increasing kind of conversation around digital solutions being developed for trusts, yet those commonly frame PIFU or patient-initiated follow-up as a matter of appointment booking. So many of those solutions are predicated on this idea that an appointment is the default of what a patient needs and where patient care is delivered, and that they couldn't receive more effective or timely care through other means. And we know from shadowing healthcare staff that patients on a PIFU pathway get in touch with a variety of queries that don't necessarily need a hospital appointment. For example, they might want advice to manage their condition, to discuss a flare in their symptoms, and they're not quite sure whether or not they need to be seen, or a prescription for their hospital issued medication. In many cases, those appointments aren't actually the quickest and most effective solution. If an appointment is required, the opportunity to kind of message in advance, have a conversation with the patient, allows relevant investigations to take place, or for a brief period of symptom monitoring before kind of defaulting to face-to-face appointment. And number two, there aren't actually many appointment slots available. So predicating PIFU on this idea that a patient should just be able to book in into a slot doesn't really work. We know hospitals have incredibly high volumes of outpatient appointments that are typically booked months and months in advance. The only real conceivable way to create that resource would be for outpatient departments to start ring fencing specific clinics for demand, but restricting patients' options to book an appointment when they could get help they need in other ways only is going to add to that growing backlog and puts increasing pressure on trusts that are already struggling with kind of elective recovery. So we really believe that triage is widely missing from that conversation around PIFU today. And it's a belief that's grown out of our learnings and experience in primary care and spending a lot of time speaking to secondary care staff. Next slide, please, System. So we believe NHS providers should use PIFU to open digital channel of communication that allows patients to get the specialist support or advice they need without always needing to defaulting to booking an appointment, but also supporting healthcare staff to be able to better triage and respond to those patients as a team. So we think that would enable patients and staff to communicate really easily and safely outside of appointments or before a follow-up is even booked. And our lessons from primary care, the vaccination programme, working with hospital teams around England, show that seamless communication can, one, transform the experience of care for patients, two, save staff time, and three, ensure more patients waiting for care get the help they need quickly. PIFU shouldn't be based on patient-led appointment booking, but approached as a general patient-initiated triage with communication at its core. It should be enabled for all patients, where you've got the appropriate backstops of clinician-led follow-up to ensure that patients aren't left behind and you're not worried about high-risk patients. Next slide, please. So what's the impact of that? So we project that adopting that approach to PIFU could help us reduce unnecessary patient follow-up appointments by up to £2.5 million per year under the current targets, giving back roughly £300 million each year that the NHS could use towards caring for other patients in need. That's based on learnings from primary care and secondary care. We know that triaging has shown how simple communication software can help patients access really appropriate, really timely care. For example, the ability to remotely share an image of a skin condition or a wound for review. And as a result, services can better manage capacity and allocation of resources, more face-to-face appointments are actually freed up for those that need to be seen, and patients receive better continuity of care. It also gives patients greater autonomy to manage their own care when they have a single point of access to a specialty they're already known to and already under the care of. It also gives staff the ability to easily triage those requests as a team, reducing the dependency on an increasingly overburdened and understaffed system, and allowing healthcare professionals for a quick and effective way to manage requests so they can provide better care for patients and also manage patient expectations. That helps services meet high patient demand, it helps reduce appointments that aren't needed, and frees up time for direct patient care. So that's why we built our PIFU solution with triage at its core. And before showing you a demo, I'm going to hand over to Aimee and Sandie, who will talk you through how they're implementing PIFU at University Hospitals Leicester. Thanks, Dustin.
Thank you so much, Satya. Over to you, Sandie.
Thank you. Good afternoon, everyone. My name is Sandie Martin. I'm an improvement lead at University Hospitals of Leicester, and today I'm joined by my colleague Aimee Geary, Strategy and Partnership Manager. And currently we're both working on outpatient transformation in UHL, primarily focusing on the implementation of patient-initiated follow-up. Next slide, please. UHL is one of the biggest and busiest NHS trusts in the country, serving about 1 million residents of Leicester, Leicestershire and Rutland. We started implementing PIFU in August 2021 and now have over 10,000 patients on a PIFU pathway. This is giving patients and their carers the flexibility to arrange their follow-up appointments as and when they need to. We are already receiving positive feedback and quoting one of our administration managers, as long as the clinicians clearly indicate on the outcome sheet that the length of time of PIFU, it's working well, adding PIFU straight from the clinic onto their waiting lists with the help of robotic process automation managing the waiting list. And this has made a significant difference to our data quality. To quote a consultant in one of our services, at a time when appointment slots and waiting times are a struggle, PIFU was assisted with appointments being booked for those that are in need of a clinical assessment, and in addition, reducing DNAs and cancellations. We've implemented PIFU across a majority of our outpatient services, such as dermatology, allergy, orthopedics and trauma, and respiratory, and this is growing. Next slide, please. To start the PIFU journey, it is firstly a mutually agreed between the patient and their clinician. And if this is agreed, the patient is given a generic PIFU patient leaflet. It is then the clinic coordinator that receives that clinic outcome and adds the PIFU outcome onto our PAS system, putting the patient onto the service's outpatient waiting list. During the period of time the patient has the PIFU pathway, the patient can initiate at any time, and to do that, the patient calls the service and is booked into an appointment that is either face-to-face, over the telephone, or virtually. At that time, the patient can restart the PIFU pathway, or it can be decided they are booked into a follow-up appointment. But should the patient not initiate a follow-up during that time period, UHL are using RPA, robotic process automation, that removes the patient from the outpatient waiting list, discharging them back to the care of the GP, with RPA also sending a letter to the patient letting them know that their PIFU journey has ended, and should they have any concerns ongoing, they should report and return to their GP as the first point of contact. Excuse me. Next slide, please. We are largely implementing PIFU manually through phone calls. We have a central booking team who manage these calls and book the patients into their appointments within a time frame that is specified by each service. If there are no appointments available, our central booking team direct that request straight to the service for them to manage. In most of the services using PIFU, patients are not triaged, being booked into an appointment. However, some services have a kind of triage, as the patient go directly to the consultant secretary, who takes a detailed message for the consultant, who then decides on when and if they want to see that patient, or if it can just be sorted over the telephone. Next slide, please. However, there has been some challenges on the way, and some key challenges throughout the process of implementing PIFU have included: firstly, the added burden to our admin teams, who are managing the waiting lists and finding appointment slots for PIFU patients. Secondly, there have been additional typing and dictation needs, which gives the patients on how and when to initiate their follow-up. One overarching problem is that clinics are already overbooked, with little or no capacity left for PIFU and patient requests. We've also received feedback from clinicians that they feel that PIFU is not flexible, as they are not able to communicate with their patients quickly. And lastly, the concern if patients lose information they are given in letters. We have already implemented solutions to improve some of these challenges, one being RPA, used to support our admin teams, and is now live across all PIFU waiting lists within UHL, with the additional use of Click to find available clinic slots. We created a PIFU template using a footnote that automatically adds service-specific information to our dictated clinic letters, saving time on typing and dictation. And from the start of our implementation, we have been nothing but honest with our services that the benefit of PIFU would not be visible for around 3 to 6 months. But we have supported our teams in amending their clinic templates to enable them to run as a hybrid clinic, using nurse clinics, nurse telephone clinics, when possible, which has stopped the overbooking of consultant clinics. We are exploring and already applied DORA as an automated service, replacing general clinics to free that capacity for our PIFU patients. For quick communication and an alternative to get information to our patients other than paper, Accurx PIFU model will hopefully be the solution to this challenge. Next slide, please. We are really looking forward to using Accurx PIFU solution in 4 of our outpatient specialities to start. Some of the key benefits that we think we'll see are allowing patients to make contact via a link. This will remove pressure to our admin teams and mean that our staff can respond to requests as and when it suits them, mitigating the need for back and forth phone calls if a call is missed. Healthcare teams can manage incoming requests and triage them prior to booking an appointment. We hope that some appointments will be avoided through communication through Accurx. Our teams will be able to assign messages between one another, so that it is clear someone has taken responsibility for a particular patient request. Through Accurx, we also will be able to send information to our patients electronically, avoiding the loss of information. Next slide, please. The services we have chosen to pilot Accurx PIFU model has been chosen due to them not fully implementing the PIFU pathway as yet. And we hope this model will encourage them to start their patients on the PIFU journey. This will hopefully reduce routine booking, able to see patients when their symptoms flare or become uncontrollable, allow their patients to get in touch instead of booking them an appointment, and improve services, DNA rates, and booking slot utilisation. Thank you. I'll pass you back over to Dustin.
Thank you very much, Sandie. So I think that's been really great. We got some context from Satya about kind of what PIFU is and why it's important. We got some great information from Sandie about, how it's actually been implemented and what some of the challenges are. But the last thing we're going to move on to is an actual demo. What people really want to see is how does the product work today? What does it look like? And for that, I'm going to be handing over to my colleague, Ali.
Great, thanks a lot, Dustin. Today I'm going to be using a test patient called Emit Mystery to take you through the demo of how our PIFU product works. And I'm going to be showing you 3 flows. So first of all, how the healthcare professional can add a patient to a PIFU pathway through Accurx. Secondly, how the patient can get in touch when they need to contact the service. And thirdly, how the healthcare professional can handle that request that comes in. Great, so when it is decided that a patient is applicable for a PIFU pathway and that patient agrees to being placed on the pathway, the healthcare professional can send a PIFU link to the patient via SMS directly through Accurx. They can also attach additional information to that message, more information about the PIFU pathway, for example, and that PIFU link that is sent in the message will be unique to the service who is placing the patient on PIFU. For those of you who are not familiar with Accurx Web, this is the page that you land on once you log in. Accurx Web is accessible via any via any web browser, and it's available to any NHS professional through NHS Mail single sign-on. To search for a patient, you need to enter both their NHS number and date of birth, and you do need both of these details. This is because Accurx Web integrates with the personal demographic service of the NHS Sign. So I am going to now enter the NHS number and date of birth of our test patient, Emit Mystery, to show you how PIFU works. When I click on search, that then takes you to the main features of Accurx Web. And first of all, you'll see the name and demographic details of your patient at the top of the page to confirm that you've searched for the correct patient. And then you can use the 4 main features of Accurx. So first of all, you could conduct a video consultation with your patient, and you can include up to 50 participants. For example, if you want to add a family member or another consultant or clinician to the call. Secondly, you can message a patient via SMS, and you can include attachments, and you can also request that your patient replies to you. Thirdly, you can request a summary of your patient's GP medical record. And last but not least, you can contact your patient's GP practice directly without having to actually know their contact details. To add a patient to a PIFU pathway, we will use the message patient feature. So when I click into new conversation, that will bring up the compose message screen where the mobile number of your patient will automatically be populated. You can then select a pre-filled PIFU template. So in this example, we're going to pretend it's the diabetes service and use a diabetes PIFU template that will be made for your service. So here it says, hi Amit, as we discussed in your last appointment, you can now get in touch with the diabetes team about your care or when you need to be seen. Please use the following link if you need to contact us. And that link is then specific to the diabetes service. The clinician or healthcare professional is able to edit that message if they want to. And they can then attach up to 5 documents, for example, if they want to tell the patient what symptoms to look out for, or give them more information about their PIFU pathway that they've been added to. Once I then click on send, that conversation will appear back in the healthcare professional and the team's shared inbox in Accurx web. Great, so that's the first step of adding a patient to a PIFU pathway. I'm now going to move on to what happens when the patient wants to submit a request. So that patient will receive the SMS and can click on that link that they receive and follow the instructions to submit their request when they need to. And they can access that link through any web browser. So here is the SMS arriving on Amit's phone. When he clicks into that, he sees that exact message that we just typed or just sent. Imagine now some time passes and maybe Amit has a flare-up in his symptoms and wants to get in touch with his diabetes team. He will click on that link and that will take him to the request flow via his web browser. And at this point, he has 3 options. So he can submit a medical request, for example, if he has symptoms that he's worried about. Secondly, he could submit an admin request. Maybe he needs to change or cancel a scheduled appointment. And lastly, we give a link to some NHS online guidance. So in this example, we're going to go through the medical request flow. So if the patient clicks into that, first of all, we just want to check that this is not an emergency situation. So we give the NHS 111 emergency guidance, and we ask the patient to confirm that they do not have any of these symptoms and it's not an emergency situation. Once they do that, they're asked to give some details of their request. So first of all, to describe the medical problem. In this example, Amit says, I've been feeling very tired recently. The patient is then able to add photos to their request. So maybe if this is a dermatology request and the patient has a skin rash, they could add some photos of their rash. They are then asked to give details of how long the symptoms have been going on for and whether they've gotten better or worse. And they're then also able to put in some additional information. These questions are optional, so the patient doesn't have to fill any additional information in. Once they go to the next screen, we ask for some details about the patient, and there are 2 ways in which this could be done. First of all, the patient could be submitting details about themselves or submitting a request for themselves. And secondly, someone else could be submitting a request on behalf of the patient. For example, if the patient has a carer or they're too young to submit their own request. In this example, we'll just assume that Amit is submitting the request on behalf of himself. So he puts in his name, date of birth, postcode, and his mobile number. And we then ask the patient if they're able to verify their mobile number through a code sent to them via SMS. And we ask for all of these details and to verify the number so that we can match the patient request to a real patient within the spine. If they don't have their mobile phone with them, it's not a problem. They can continue to submit their request, and we just have to do something slightly different within Accurx web to match it to a patient. So Amit gets that code to his phone and confirms, and he's then given the chance to review his request before he submits. So if he has made any errors in submitting his request, he is able to go back and edit those. If he's happy with what he's written, he's then asked how he would like to be contacted, and he has 3 options: via text message, phone call, or video call. So in this example, we'll just say via text message, and he can then submit his request, and he gets a confirmation page that his request has been submitted. And the importance of this page is that the patient is given an indication as to how long they could expect before their request will be viewed by their healthcare team and they might expect a reply. We've defaulted it to 2 working days, but the specific healthcare team is able to edit this to what they believe is most appropriate. Great, so that takes us through step number 2, where the patient has now submitted a request. I'll now take you to the final flow, which is what happens back on the healthcare professional side once a patient has submitted that request. So as soon as the patient submits their request, that will arrive in the services team inbox, and the team is then able to assign that request to an individual clinician or admin member within the team. And this is to make responsibility of the patient request really clear. So for example, if one of my colleagues has been treating a MITS mystery previously, then I would probably want to assign a MITS request to my colleague so that they can continue his care. The assigned user is then able to triage the request and respond to the patient via SMS, really simply through Accurx. So going back into Accurx Web, you'll see on the left-hand side that notification number will increase when a patient request arrives in the inbox. And if we go into conversations, you'll see 4 folders. So first of all, my conversations, which are all conversations that are assigned to me as a healthcare professional. Secondly, the unassigned folder, which is where any PIFU requests will go. Thirdly, the done folder for all patient requests that have been dealt with. The healthcare professional is able to make them done, and then all for an overview of all requests. If we go to unassigned, you'll see the request that Emit Mystery has just submitted with a tag to say it's a patient follow-up request. And if we click into that, the healthcare professional is then able to see all the details of the request. If we go to where it says unassigned, that's where I'm then able to assign this to anyone within my team. So this drop down will be all the team members within your team. And I could assign this to one of my colleagues or to myself. And at that point, there will be an audit trail of who assigned the request to whom and at what time. This assignment is also really helpful. For example, if I've assigned this request to myself and I'm then going on leave, in a couple of days, I can then assign this to one of my colleagues to continue that conversation with Emit and make sure his request is properly dealt with. At this point, the healthcare professional can then send a message to Emit via SMS again to respond to his query and can either ask him for more information about his request, send him some guidance if that will help him sufficiently, or ask him to have a phone call or book in an appointment, so can deal with the request as appropriate. Great, so that takes us to the end of the demo. Thank you so much. I think I will be handing back to Dustin now, who will, I think, take us to some Q&A.
Thank you so much, Ali. It's always so exciting to see our product in action. So I think that's now the end of the actual deck, but we're going to hop into the Q&A, just like Ali said. So I'm just going to stop sharing my screen. I'll bring up the Q&A and we can start getting to some of these questions. So I think the first one I'd like to do is, you can see right here, it says, how do you manage patient booking an appointment, but then DNAing? Do they come off of PIFU? I think for this one, could I hand over maybe to Sandie or Aimee? Would one of you like to take that one?
Do you want to take it, Sandie?
Yeah. So currently, all of our DNAs, if they're a follow-up patient, that decision comes from their clinician. So if we had a patient that initiated a follow-up, but then they were to be DNA'd, they'd follow the same process. Their last letter would be looked at, and then they would be thought if they could be discharged or not. So it's purely a clinician decision. If they were decided to be discharged, then our clinic coordinator would run that discharge on the system. If they were decided that they were going to give them a phone call and continue the PIFU journey, then again, that patient would be identified, informed of that, but it would be a clinician decision.
Great, thank you so much. Then I think the next question we have is, how do you expect this digital PIFU solution will reduce the administrative burden that comes alongside the demand for outpatient care for your staff? I think this is another one that I'd throw your way, Aimee and Sandie. I'm not sure if you'd like to switch this time.
So when we initially started rolling out PIFU, one of the biggest barriers from services was that it was going to be increased admin burden. So we've had RPA, so that would be the solution for the patient to be put on a outpatient waiting list, and then they wouldn't have to actively manage the waiting list. The robot would do that, and then the robot would discharge the patient once their PIFU pathway come to an end. Now, how Accurx would prevent the admin burden is, at the minute, the patients ringing up the service. The services are already absolutely overwhelmed at the moment. So, and also if then they try and call the patient back, it's not always convenient. So Accurx, Sandie and I found through using Accurx for validation, we're getting a lot more responses from patients because the patients reply when it's convenient to them. So that's how we see that it'll be working, because okay, yes, the admin will have to do something, but they'll hopefully only be having to do it once. They won't be having to chase in, and it will just be a smoother flow between clinician, admin, patient, backwards and forwards. I hope that answers it.
Yeah, I think that makes a lot of sense. Thank you so much, Aimee. So now moving on to the next one, we have, how do you envisage that a digital triage-first PIFU solution will make such an impact on waiting lists? I think this one we could maybe throw over to Satya.
Thanks, Dustin. I think if we just talk about waiting lists to begin with, so we know that there are lots of patients waiting for their first time consultant-led care, which is, usually kind of 18-week pathway, the 2-week wait pathway. However, lots of appointments are being filled up by patients just being added routinely for 6, 9, 12-month follow-up. In pediatrics, it's sometimes 18 months to be seen for a follow-up appointment. Now, at the point those patients are seen, they may not actually need that appointment at that time. They might have needed it at another point in time, and we have block booked a clinic, which prevents us from seeing those patients who are on those waiting lists and waiting kind of beyond 18 weeks for care. So that's why when we talk about kind of a digital first PIFU solution, we believe that patient care doesn't only happen in appointments. As kind of Aimee and Sandie have spoken about, is that we have staff monitoring these phone lines, etc. That care is already being delivered outside of those face-to-face appointments, whether that's providing advice and guidance, remote monitoring, opening up communication lines between patients and their healthcare teams. So we think that inbuilt triaging step in digital PIFU solutions is really important, because it unlocks the potential to provide the right care to patients more effectively at the right time, which supports that kind of care that already happens outside of those appointments. It gives patients a really clear route to contact relevant services and reduces the burden on services that aren't actually needed, or having a routine follow-up appointment in 9 months booked at the point they then don't need it. So we spent a lot of time kind of within primary care doing this very well and at scale, and increasing in secondary care. So we feel like there's better care for patients to be delivered by having digital first triage solutions, which also allows patients to manage their expectations and again kind of gives patients autonomy to be more involved in their care. I think that in turn has a huge impact on the backlog, so those patients waiting for those first time appointments.
Great, thank you so much, Satya. So I think, let's see what the next one is. It's great to see so much engagement in the Q&A section. So I think this next one is, will triage add additional work for healthcare teams? I think this one maybe we can throw back your way as well, Satya, if that's all right.
Yeah, that's fine. And so I think we spent a lot of time speaking to trusts about how they're implementing PIFU, and nearly universally it has been through phone lines. So that is healthcare teams who are outside of their normal roles, so like a clinical nurse specialist in an IBD team, manning phone lines from 2 to 4 p.m. That's what we heard from some trusts, where patients could phone in, and then they would spend the next few hours of their shift trying to solve all those patient queries. Now, all of that stuff is already happening, but in really inefficient ways. So patients phone through, they leave a voicemail, and they're told, you'll hear back from us within 24 to 48 hours. If it's outside of 2 to 4 p.m, don't leave those voicemails, but patients still invariably do. And that means that healthcare staff then have to pick through those. And one of the trusts we spoke to said they get roughly somewhere between 30 and 50 calls a day. So all of that work is still happening. It's actually far more of an administrative workload than having a really seamless way where patients can get in contact with you in a single point of access, having a healthcare team that can actually work as a team and not one individual in the team to manage those incoming requests, because often not all of them are a patient's had a flare in their symptoms. Often it is very simple, like, I can't actually attend my appointment, but I still want to be seen. Can I bring it forward? It could be actually I just need a repeat issue prescription for my hospital medication. So not all of that is dependent on one specific role in the hospital, and actually a lot of that workload can be shared as a team, which is not happening right now. happening in really inefficient, clunky ways, both for a patient experience. For a patient, you're phoning a voicemail with leaving a query and then hoping that it'll be heard and responded to and that you'll get a reply, but no indication of when, what time. So exactly like kind of Ali showing you in that demo, you can set very clear expectations to patients about one, what PIFU is appropriate for, when they can expect to hear, which the service can decide what's appropriate for them. And two, it gives a really clean and neat and coordinated way for hospital systems and hospital services to manage those incoming requests, rather than having this very kind of scattergun, haphazard approach of phone lines that need to be manned in specific hours and voicemails, etc.
Thanks a lot, Satya. So I think the next one I can see here is, this is so interesting, thanks. How do we get in touch? I think for that one, maybe over to you, Ali.
Yep, so there are two ways you could get in touch, either emailing inquiries@accurx.com. We won't ask you to remember that. We'll send a follow-up email after the webinar and we'll put that email in there. Alternatively, you can go to our website at www.accurx.com and you can register your interest on the PIFU page there, but we will share this all in the follow-up email.
Great. Thank you so much, Ali, for that one. Just looking at the rest of the Q&A now then. Okay, I can see one more here. It says, thanks for the demo. How does assigning it to different team members work? Does this mean that anyone in the team is able to get in contact with the patient? I think maybe this one I'll throw back to you, Satya.
Yeah, well, maybe I should send this Ali's way, but I think, Ali, if you feed in, but I think, so essentially the way this works is that services can be set up as specific teams. So if you're working across a dermatology service, whether that's admin users or clinical users, anyone who's having conversations or interactions with the patients, that is very much dependent on who you want within that team. And that way you can manage incoming responses as a group of people who are responding and responsible for a specific service and respond back to patients. So that's very flexible by design to ensure that actually if you are a group of community heart failure nurses who are using PIFU for patients getting contact, and you are the ones who want to be responding to those patients, or the clinical nurse specialists in the IBD team, or a mix of roles, admin and clinical staff and non-clinical staff, it's very flexible for you to be able to set the team up in whichever structure you want, and those people will then have access to the patients' incoming requests, be able to assign things to their colleagues if it's not for them, and then respond back to the patients.
Great, thank you so much, Satya. So just looking at the time we have left here, I think, okay, maybe we have time for one more, looking at the Q&A. So have you considered how the process might need to be improved to work for those with mental health problems? If yes, would value some advice. Would you like to take that one as well, Satya?
Weird, although I've just seen a comment that the audio quality is apparently very poor, so I do apologise. We will share the recording and kind of a written Q&A as well for anyone who's not able to follow. And so in terms of kind of making the process appropriate or work really well with mental health problems, we are actually used by a lot of mental health trusts to contact their patients and keep in contact with their patients. What we found is for that specific vulnerable group of patients, SMS is often a lower barrier to entry in terms of accessing their care, having more frequent touch points with their patients, and better communication without necessarily needing a face-to-face for every interaction. So certainly over COVID, one of our biggest learnings was that mental health trusts really adopted text messaging for their patients, because for that specific group of patients, it worked very well. They've had direct feedback from patients that it was a better way of keeping in contact about their care. So we're very mindful that the reason why we build a lot of our functionality around SMS is because it is the lowest barrier to entry for patient engagement. And that's why 50 million patients across kind of a range of medical conditions, backgrounds, etc., have been able to use Accurx very well. Now it's something that we'll continue to build on and iterate on, as we always do with all our products. So if you have very specific needs, we'd love to hear from you, and please do get in contact, because that's exactly the purpose of having webinars like this. We want to kind of be very accessible and cover as many patients as possible. But generally, we found SMS is a great way to engage a very large majority of the patient population.
Thank you so much, Satya. So I think that's all we have time for today. Obviously, we weren't able to get through all questions, but always feel free to reach out. We're always happy to kind of hear opinions, questions, anything from anybody, whether they're a current user or potential user. So by all means, please do get out and we'll do our best to kind of respond to you and have a conversation. Otherwise, just before we sign off, I want to thank everyone for their participation today. I thought it was a great session. Thank you, Ali. Thank you, Aimee. Thank you, Sandie. Thank you, Satya. And thank you everyone in the webinar as well. I hope you have a nice rest of your week and enjoy the wonderfully cooler temperatures than yesterday. All right, take care, everyone. Bye-bye.